accommodate more than 100 candidates because there was an issue with the Google Meet, and perhaps we will have to also change the link in between if the technical issue gets resolved and we are able to help other members to join. Good evening, everyone. Welcome to the CBT webinar. And today we are not just going to talk about the cognitive distortions, but we are also going to learn how to gently outwit these cognitive distortions with our clients, with our patients, and maybe with ourselves too. We'll try to keep this webinar focused as much possible on the practical tools because our goal is to help you learn better tools and techniques, and hopefully you all leave better equipped with the CBT principles and techniques, and without needing a 100-page or a 500-page book or a manual by your side. Um, this webinar is a collaborative initiative by SoulaceSpace, which is my organization, and Sophiyana Loka, which is led by Ashish. Ashish is also there today amongst all of us. And we are delighted to bring this learning experience to all of you. And let's get started. So this is about me. I am Dr. Tanuja Kaushal. I'm a clinical psychologist and I have over 10 years of work experience in the field of clinical psychology. I completed my studies from GMCH Chandigarh and AIIMS New Delhi. And I feel that CBT I use regularly, and I feel that this is one of the most effective and one of the most evidence-based practices for wide range of emotional issues, and it's quite flexible, and it's very valuable tool across different disorders. And I feel that if you understand CBT well, it becomes very easy to understand ACT, acceptance commitment therapy, dialectical behavioral therapy, and other third wave therapies. So CBT acts more like a base, and I hope that my experience helps add value to your understanding of CBT. Moving on, we also have Megha Garg with us today. Megha, would you like to introduce yourself, please?
Am I audible?
Yes.
Hello everyone, my name is Megha Garg. I'm a counseling psychologist and today I'm also with you to learn and also help you to understand the CBT concepts in a deeper way. So I'm practicing psychologist from last 2.5 years and I'm currently associated with Tanuja ma'am's SoulaceSpace, and basically we used CBT and I love CBT a lot. So today let's learn, grow together and know more about CBT. Thank you.
Absolutely. I think Megha always brings up CBT across different clients, and she's so much inclined towards this technique, this approach, that every now and then, whenever she's managing a patient, she always comes up with a CBT conceptualization and CBT focused goals. So let's start. The next slide tells a little bit about what CBT is. I'll try to put it simply. CBT is basically a type of therapy which helps people recognize and change negative and unhelpful thoughts so that they can feel better and cope with life in a more effective way. Now, we'll understand this with the help of an example. Imagine that your thoughts, they are like a pair of glasses that you're wearing. And sometimes, these glasses, they get smudged with negative or distorted views. And because of that smudged glasses, it makes everything look worse than it really is. And CBT is like how to clean those glasses. CBT helps you spot those smudges or those negative thoughts. And it also helps you to replace those smudges or those negative thoughts with more realistic ones. By changing how you see things, you start to feel better and make healthier choices. So I always tell my clients that with CBT, we are not trying to make you more positive, or we are not trying to make your thoughts get more positive. What we are trying to do here in CBT, through CBT, is we are trying to make your thoughts more balanced. We are trying to make your thoughts more rational rather than being toxic, way may positive, right? So it is about reframing negative thoughts into more balanced thoughts, not reframing the negative thoughts into positive thoughts necessarily. This is the heart of CBT. Now, this triangle, CBT triangle, I want all of you to please pay full attention to this CBT triangle, because every now and then we introduce this triangle to our clients during the psychoeducation process as well. And for you to practice CBT, it's very important that you understand this core idea, this very important idea of CBT triangle. It shows how our thoughts, our feelings, and behaviors are interrelated, and one affects the other. What we think affects how we feel, and how we feel influence how we behave. And by changing how we think, we can improve how we feel, and thus our actions get changed. It's basically about fixing one part or modifying one part of the triangle to help the whole thing get better. One example of this triangle, we can take an example to better understand this. Imagine that you have to give a big presentation, just like I am giving this big presentation. Imagine you have to give a big presentation at school or at your work, and sometimes we all go get those thoughts, oh, I'm going to mess it up, and everyone will laugh at me. Now, because of this thought, you really start to feel anxious and nervous. This is a feeling. Thought is, I'm going to mess it up, people will laugh at me. Feeling is, because of this thought, I start to feel nervous and anxious. And as a result, I might not appear for this presentation. I may avoid practicing for the presentation, or sometimes one may even skip the presentation because of anxiety and fear. In CBT, what do we learn? What do we do in CBT? We learn to spot the negative thoughts and we challenge them. So instead of thinking I'll mess it up, we'll try to think, okay, I've prepared well and I can try and do my best. Now, this new thought, it helps you feel more calmer, more in control, more confident, and you're likely to practice and then do well. So you see how negative thought leads to negative feeling and negative behavior, and how a rational thought, which says that okay, I am well prepared, try to do my best, it leads to a more balanced feeling, and thus a balanced or a practical, reasonable behavior, which is appearing for your presentation. Next is these are three very important concepts, guys, that you should all know before you practice CBT. One is negative automatic thoughts, and the second is core beliefs, and third is thoughts. So I have tried to put it in a onion analogy. You think of your mind as an onion with three layers. The outer layer is the thoughts. Thoughts are what we observe on day-to-day basis. Like, say for example, it's the weather is sunny today, or I have to do a lot of work today. These are normal thoughts on the surface layer, what we can observe. On the inner layer are negative automatic thoughts. Now, these negative and automatic thoughts, which we also call NATs, they are like very quick, automatic, autopilot. They pop out of nowhere without warning, and they can be negative. For example, if I make a mistake, I automatically think, oh, I'm terrible at this. Like I can tell you about my negative automatic thoughts. So I'm expecting a lot of psychology students there, and we all know how our relationship is with statistics. So whenever I make a mistake in stats, I'm always like, oh, I can never do maths right, I can never do stats right. So that's my negative automatic thought, which comes out of nowhere. It pops in my head, right? And this is how NATs are. And then if we go a little further in the onion layer, in the core of mind, at the very core are core beliefs. Now, core beliefs, they are deep rooted and usually long held ideas. Long held meaning we have been holding them for a pretty long time, usually since childhood or adolescent years. And these ideas are about yourself or about the world around you. Simply put, core beliefs are guiding principles of our life. Now, these guiding principles can be balanced or they can be super negative. Usually, ये जो core beliefs होते हैं, they are absolute and very global. For example, common core beliefs which we find in psychological disturbances is people cannot be trusted. Now, this is very global and an absolute core belief, or I'm not a good person, I'm not good enough. This is also a core belief. Like a positive core belief which I carry with myself is that I deserve respect or I deserve to be loved. This is a core belief, it's a positive example. A negative example can be people cannot be trusted or I'm not good enough. In CBT, we start by noticing quick negative automatic thoughts because they are easier to spot and also slightly easier to change. Thoughts are usse bhi zyada easier. Negative automatic thoughts, yes, easier. And the right way to address the negative thinking is NATs को identify करना, spot करना और उसको change करना. And these negative automatic thoughts sometimes they come from deeper core beliefs, which we work upon over a period of time. We reach core beliefs like through strategies like downward arrow technique, and we can work on the deeper core beliefs also in the further course of CBT. But we start with entities, and understanding these layers of onion or mind, they help us know how to make real and lasting changes. Now, next is so in order to make CPT easier to understand and apply, we have divided the process of CPT into three clear phases, and this structure will help you to know what to focus on during the each phase of therapy. The first phase is initial phase, which usually lasts from first to 4 sessions. And during the initial phase of CBT, we build rapport with the client, we understand their concerns, their complaints, we explain what is CBT, what is that heart of CBT, the triangle, and we also try to start identifying the negative automatic thoughts. Now this is what we do in the initial phase. In the middle phase, which lasts roughly around 5 to 8 sessions, we go deeper now, and we start challenging the unhelpful thoughts. We introduce cognitive and behavioral techniques, for example evidence testing, probability testing. In behavioral techniques we can talk about activity scheduling, deep breathing exercises. So we do the real work in the middle phase, and we begin to change the patterns. The last phase, usually from roughly from 9 to 12 sessions, this is about consolidation. Consolidation phase meaning strengthening the newly learned skill. So whatever the client has learned, we try to strengthen that, and we work on preventing the relapse. Plus, we help the client to become their own therapist. Somebody has their mic switched on by the name of RR Emotion. Can you please switch off your mic? Thank you so much. Thanks. All right. So this is the structure. Now moving on. Okay. So we are talking about initial phase. Can we have the next slide, please? Right. So making a strong start in therapy. Okay. What do you do in the? Let's talk about first session. What do you do in first session? I'll tell you simply put. Starting a first session, you usually have quite a fixed kind of a script for the first session. And how it goes is when the client is entering your room, first of all, try to be warm and little friendly, but while maintaining the boundaries. You give a smile, welcome them, make them sit down, and after that, you ask them that okay, this is your name, and maybe you tell them that I am Dr. Tanuja, and I have been practicing in this field for so many years, or this is my background, my work ex, and then you tell them that you talk about this confidentiality. You tell them that whatever we are going to discuss in this session is going to be confidential. It is going to be between the two of us unless until I feel that there is a threat to your life. If there are some life threatening thoughts, ideas, or behaviors, in that case I can reach out to your treating psychiatrist or your immediate family member. Rest of the information is between the two of us. This is how you tell them about confidentiality. About rapport building, simple questions you can ask. Which series are you watching these days? You can discuss about the actors, you can discuss about the movies that the client like, you can discuss about the kind of genre that the client reads, or maybe the kind of music that the client likes, or the sports that he's or she's playing. That's how you build rapport. Rapport building, simply put, rapport is a feeling of trust and safety. the connection which the client is able to feel with you, and the client will be able to feel that connection only if they are able to relate with you. That's why we focus a lot on, reading, improving your awareness, networking, watching things online or in movies, so that you have some content to talk about and build that connection or that rapport with the client. So rapport is basically, the client, if the client feels that I feel safe talking to you, you have a good rapport. So how do we do it? We use a warm, soft body language. We show genuine interest and empathy. We listen more than we speak, especially in the initial sessions. Avoid judgment. Avoid rushing to fix things. Please allow your client to speak. It is said that when your client is speaking, listen to the client, because they are telling you their diagnosis, or they are actually telling you what are the things that you need to work upon. वो आपको goals बता रहे हैं, वो आपको problems बता रहे हैं, तो ध्यान से सुनिए. We also ask in the first session that okay, we are here, बताइए क्या दिक्कत आ रही है, what is the concern, what are you here for. Simply you ask the chief complaints. So this is what we usually do in the first session. Usually, it is said that therapy is highly tailor-made, which I 100% agree. Same kind of structure cannot be applied with every client, but during the first session is more or less similar. Similar in the sense, the kind of things that you have to say to the client, right? We can move to the next slide. Okay, this is very important. Therapeutic alliance. Now, if you think of therapy, maybe Megha, can we move to the next slide? Yeah. So if you think of therapy like a boat, you and the client are in the same boat together. The client is holding a map because they know what they want out of therapy. They have their goals in their mind, and the therapist, they help in paddling. They offer support. As a therapist, you offer tools, techniques, and direction. But in order to move forward, the boat to move forward, therapist and client, they both need trust and they both need teamwork, and that's the bond. So three things are important in therapeutic alliance. One is you have clarity of goals. How do we set goals? You simply ask the client very simple question in first session: what are your expectations from therapy? What are you looking forward to, or how can I help you? So you ask them clearly what is their expectation. So number one thing in therapeutic alliance is goals. Number two is tasks. Tasks money, the things that you do, the techniques that you apply. You're doing deep breathing with them, or you are doing downward arrow technique with them, or you are doing cognitive restructuring with them, or you are identifying cognitive distortions and modifying them. So second is tasks, and third is the bond. Bond is again the connection that you share with your client. And again, for good therapeutic alliance, you have to listen properly, you have to be empathetic, you have to work collaboratively, you have to be consistent, meaning showing up for your client. Avoid unnecessary cancellations, pre-scheduling, rescheduling, and be consistent may also mean following up with your client and be reliable. Simple language should be used. And what is the difference between rapport and therapeutic alliance? I would say rapport is making the client feel relaxed and safe in the therapy room, and therapeutic alliance is working with the client. It's a working relationship, collaborative effort. Okay, moving on. I hope we are on time. Okay. Uh, CBT assessment. Okay, so CBT assessment used to understand the client's current psychological functioning. Now, this is very, very important CBT assessment, because this is on the basis of assessment, you're going to set your goals, and you're also going to more or less decide that what kind of techniques you're going to apply. Initial step hai, we need to get a very clear picture of client's current emotional, cognitive, behavioral, and physical symptoms. What do we focus on in this session? We focus on severity, like how intense the symptom is. This can simply be done based on a rating scale. You can like ask your client that um, on a scale of 0 to 10, where is your mood? 0 being crying spells, the mood is very bad, and 10 being elated, very happy. So how would you rate your mood currently? Frequency, meaning how often does it occur. So say for example it's a client with the trichotillomania, they have hair pulling issue. So you ask them that okay, on an average how many episodes are happening every day, or how many cigarettes are you smoking in a day if you are dealing with a smoking case, or over the week, if not, if it's not happening every day. Duration, if you're managing alcohol consumption, then what is the duration of one single episode of drinking? Or if you are managing OCD, what is the duration of one single episode of hand washing? Then you also ask them what how this issue is impacting their life. How much does the problem affect their daily functioning? So आप ओसीडी की वजह से काम पे नहीं जा पा रहे हो, या अपनी फैमिली को टाइम नहीं दे पा रहे हो, आपका मैरिटल रिलेशनशिप अफेक्ट हो रहा है, या आपके डेडलाइंस आप मीट नहीं कर पा रहे हो, या आपके वर्कआउट आप नहीं कर पा रहे हो, आप खेलने जाते थे आप वो नहीं कर रहे हो. सो हाउ इट इज इम्पैक्टिंग योर फंक्शनिंग इज द इम्पैक्ट. During the assessment period, we can also use rating scales to establish baselines. Now, baseline is very important because if you don't know where your client is functioning today, you won't be able to assess if CBT has been helpful to them or not over the next 5 sessions or 10 sessions. So, extremely important to establish a baseline and ask these questions. Maybe you can administer some rating scales like BDI, BAI, HAMD. Some structured scales can be can be administered, or you can interview the client simply and ask about the severity, frequency, duration, and impact. Now, for example, for anxiety, you can ask on a scale of 0 to 10, how anxious do you feel on an average, on daily basis, or today, how are you feeling today? Or for headaches, you can ask that can you rate the intensity of headache from 0 to 10? Or expenditure is another issue which can be for which we can establish a baseline, like how much money do you typically spend during the each shopping spree. For overeating, for obesity management, how often do you find yourself eating more than intended? As I said, that establishing baseline is very important because you know where exactly the client is, and you set very realistic and clear therapy goals based on this. Plus, you are able to track changes throughout the progress of therapy. Can we have the next slide? Okay, so SMART goals is a very simple technique. SMART is basically an acronym, and for every alphabet stands for a term. S means specific. Be clear about what you want out of therapy. Measurable is you track progress. So rating scale is a wonderful way to quantify the improvement. Measurable, and A is achievable. The goal should be realistic. It should not be beyond the resources of a client. The client is not able to get out of the bed because of sadness and you are asking them to go to a gym. It's not achievable. So the goal should be realistic. Relevant, meaning choose what matters to the client, not something irrelevant, like the client wants to work upon smoking management, and you are giving him absolutely unrelated goals. Say for example, I'm not able to think of anything which is not related to smoking at all. Maybe you are asking them to do puja, and the person is not at all spiritual or religious. So it does not align with their value system. This is completely unrelated to who they are or what they want to work towards. Time bound means you have to set a deadline that okay, we'll try to manage this particular problem over the next 2 weeks. We'll try to reduce the levels of anxiety. Right today, if the anxiety score is 20, we'll try to bring it to 15 over the next 4 weeks or 5 weeks. Um, Okay, so now you think of this is again an example. This is a 22-year-old college student experiencing mild to moderate depression, and he reports staying in bed most of the day, avoiding classes, feeling unmotivated, and not able to engage in activities he used to enjoy. So now in this case, how do we structure SMART goals? Can we have the next slide? So specific, I will attend my morning online psychology class from my study desk instead of my bed. Now this is a quite a specific goal, and not unrealistic as well. Measurable, at least 4 times a week. So you have set how many times a day. It becomes measurable, it becomes quantifiable, achievable. I have done it before, and I can prepare by setting up my laptop and water bottle the night before, so that it doesn't become overwhelming for the client to do 10 things at once. So next day morning, you just have to go and sit on the table and open your laptop. R is relevant. This will help me re-establish a routine and feel more engaged in academics, which matters to the client. Now, this is most important. Relevant means it matters to the client. Time bound, I will follow this goal for the next 2 weeks and then review my progress in the next session. Okay, now we come to case conceptualization. Now, okay, this is very, very important again. Case conceptualization is like creating a map, a road map to understand someone's problem. It helps in understanding or seeing what kind of thoughts, feelings, and behaviors are connected and what keeps the problem going on. What do we do in case conceptualization? We identify the main problem. We look at the thoughts and beliefs related to it, and we notice how the feelings and behaviors respond to these thoughts. We also consider past experiences, and then based on all of this information, we help the client understand and work on the problem. So how the client is basically what thought is leading to which feeling and which behavior, and what is the vicious cycle like. For example, somebody with the complaint of social anxiety. Now, because the client is thinking that if I go out, people are going to judge me, they are going to make fun of me. Now, this thought is making me so anxious, so worried. I am highly nervous. Thus, I stay inside my house. I stay indoors. Okay, this is the behavior that I'm staying indoors. There is complete avoidance. This is the triangle. Now, this triangle is keeping me stuck because when I'm staying indoor, I have no opportunity to experiment that what will happen if I go out, and thus to break this false belief, this false thought, irrational thought that if I go out, people are going to make fun of me. So unless until I don't go, I don't do behavioral experiment, which is again a great CBT technique. If I don't do behavioral experiments, this illusion will not get broken in my head. In fact, if I continue to stay indoor, what is the message which I'm giving to my brain? The message is that I am safe and secure because I am staying indoors. If I go out, something catastrophic will happen. So this is this is how you utilize that triangle, and you understand the vicious cycle in which the client is stuck. And this is exactly how you describe the problem, the case conceptualization, to the client. You discuss that, this is my understanding of your problem. Are you able to resonate with this? Are you able to relate with this? The client may or may not be. If the client is not able to relate to your conceptualization, it's all right. You understand the problem better, and you take your client's help in coming up with a better and a more relatable case conceptualization. So this is about the conceptualization. From here on, I think Megha would like to take it up. Megha, do you want to proceed? And I also will be joining you guys again. I'll be coming back to talk about some more aspects of CBT, but I think from here on, Megha can take over. Some of the middle phase is going to be covered by Megha. Megha, are you there? Okay. She's working on it. I think there is some issue, so maybe I can continue from here, and once Megha is able to, some technical issue is there. Once she's able to resolve that, then she can take it up. Okay, so this is also part of case conceptualization. Presenting problem is the main issue. What your client is coming and telling you that, doctor, I have headache. Doctor, I am not able to sleep at night, or I get a lot of anxiety. I have overthinking. So many thoughts are jumbled up in my head. So what the client is coming and presenting to you, the main issue is the presenting problem. Precipitating factor is the event which triggered it. So maybe my anxiety got triggered after an accident which I met, or the OCD got triggered after joining an office where the boss was very toxic. So any reason, any event, any situation can act as a precipitating factor, but it is important to identify what has been the triggering factor in your client's case. Predisposing factors are already existing, pre-existing factors, which makes the person more likely to face mental health issues. So predisposing factor can be, people, unfortunately, if somebody is coming from a broken family, or somebody coming from an unfortunate background, unprivileged, not very privileged background. So those kind of factors may be there, poverty may be there, and lack of awareness can be there. Some stigma could be there, or these kind of, if there are issues which have already been existing in the family or in the background of the individual, which make them more prone to development of psychological issues. Perpetuating factors are the ones which maintain. Now, the example that I quoted, social anxiety wala, usme the perpetuating factor is that the client is staying indoors. Um, and the protective factors are the strengths and resources that the client has. So, for example, somebody who is having depression, which is of moderate level depression, but the person is somehow able to do their workout regularly. Now, in this case, this is a protective factor, and we are hypothesizing, we are assuming, hypothesizing would be a better term. We are hypothesizing that if the client was not working out, the depression would have been at a severe level, may have been at a severe level. So working out is a protective factor. Or somebody who has a good social support system, who have a nice, supportive, understanding family, good set of friends whom they can talk to. So those are the protective factors. We can move on. I think we need to hurry up a little. Psychoeducation. So psychoeducation, one, you tell them what is CBT, just the way I told you, and introduce the triangle, give them examples to understand, use a lot of analogies. Emphasize on skill building. You tell them in advance that this is a lifestyle change, this is a skill building process. During the process of CBT, I'm going to tell you about certain techniques and tools which we will learn together, and you will slowly start to implement them on your in your daily life. Explain the structure of session in advance. You tell them about the initial phase, middle phase, and the termination phase. Tell them that this is a collaborative effort, this is a joint effort, we both are working on the same goal, towards the same goal. And introduce the idea of small homework tasks throughout the therapy. Next, please. Okay, so I think we have discussed this, that we tell the client that what will be the structure of a session like. We can move on. All right, so from here on, I think, Megha, if the technical issue is sorted, you can take it up. I will also be joining you guys after a few slides again. Megha, if you can switch on your camera, would be great if you're comfortable. Otherwise, it's all right.
Am I audible?
Yes, you are. Can you switch on your camera, or if you're not comfortable, that's all right.
Actually, if I switch on my camera, the PPT will not be visible.
Understood.
So this is kind of a technical issue I was facing.
No, no
So
worries. You can please proceed.
okay, so hello everyone. So here we talk about the middle phase of therapy. As we discussed the initial phase, as Tanuja ma'am said, like यहाँ पे हम CBT को इंट्रोड्यूस करते हैं, साइको एजुकेट करते हैं क्लाइंट को, पूरा उससे पहले पूरा केस कॉन्सेप्चुअलाइज करते हैं. सो इवन टिल नाउ वी हैव अ लॉट ऑफ अंडरस्टैंडिंग अबाउट द क्लाइंट कि उसकी पास्ट एक्सपीरियंसेस क्या है, करंट प्रॉब्लम्स क्या है, and a lot of things we know about the client till now. So now we talk about the middle phase. So just give me a second. Yeah. So first we talk about the structure of a typical middle phase session. So होता क्या है यहाँ पे? Basically यहाँ पे exactly real therapy work होता है. यहाँ पे हम
Hello.
client को बताते हैं.
Hello. I'm
Hello.
sorry, Megha, to interrupt you. I'm really sorry, Megha, to interrupt you. Actually, the PPT is not visible.
Okay. So PPT is not visible, right?
Yes.
Megha, I am able to see your PPT. Is anybody else experiencing this problem? Because the PPT is visible to me.
It is visible. Okay.
It's visible, I think.
PPT is
Megha,
visible. Visible.
you can proceed, Megha. It's visible.
Okay. Okay. So I was talking that here the real therapy work happen. हम यहाँ पे client को टेक्निक्स इंट्रोड्यूस करते हैं, उन्हें सिखाते हैं कि कैसे वो अपनी रियल लाइफ में अप्लाई करें. सो स्ट्रक्चर एग्जैक्टली होता क्या है? So the first step is we begin the session. First of all, हम after 4 to 5 sessions of the initial phase, जब हम middle phase में आते हैं, जो around 5th session से start होता है and 5 to 8 to 9 sessions हमारे middle phase में हमें लगते हैं. So यहाँ पे होता क्या है? तो फर्स्ट स्टेप इज बिगिन द सेशन. हम यहाँ पे क्लाइंट को ग्रीट करते हैं, हम पूछते हैं व्हाट वाज योर पास्ट एक्सपीरियंसेस इन द लास्ट वीक में क्या रहा, क्या चैलेंजेस आए, क्या एक्सपीरियंसेस अच्छे हुए, बुरे हुए, उनका मूड कैसा है, क्या सिम्टम्स है इस टाइम पे. एंड देन आफ्टर सेकेंड स्टेप रिव्यू होमवर्क. हम यहाँ पे होमवर्क रिव्यू करते हैं. होमवर्क रिव्यू का मीनिंग होता है जो भी क्लाइंट के साथ क्लाइंट एंड थेरेपिस्ट ने लास्ट सेशंस में, प्रीवियस सेशंस में होमवर्क एक बनाया होगा क्लाइंट के लिए, एक जिस पे दोनों क्लाइंट एंड थेरेपिस्ट दोनों एग्री हुए होंगे, उस पर वर्क होगा, उस पर बात होगी. फॉर एग्जाम्पल कि थेरेपिस्ट ने क्लाइंट को कहा कि आपको जर्नलिंग करके आना है इन द नेक्स्ट सेशन. तो यहाँ पे हम चेक करेंगे कि क्लाइंट ने जर्नलिंग की या नहीं, क्या वो अपने थॉट्स को लिख पाया, क्या वो अपने इमोशंस को लिख पाया, और अगर वो लिख भी पाया तो उसके लिए क्या चैलेंजिंग रहा, क्या वो उसके लिए हेल्पफुल रही एक्टिविटी, क्या वो कर पाया, क्या उसने ट्राई किया या वो ट्राई नहीं भी कर पाया. सो वी विल टॉक अबाउट ऑल दीज थिंग्स. So now the next thing is step 3, introduce skill building. This is a very important step in the middle phase. So after we identify that कि हमें पता लग गया है कि client का thought pattern क्या है, behavior patterns क्या है, so now we start talking about this the practical skills to the client. हम यहाँ पे क्लाइंट को प्रैक्टिकल स्किल्स इंट्रोड्यूस करेंगे ताकि वो अपनी रियल लाइफ में उसे मैनेज कर पाए. स्किल्स जैसे थॉट फीलिंग डिस्क्रिमिनेशन, एविडेंस गैदरिंग, एक्टिविटी शेड्यूलिंग, ग्रेडेड एक्सपोजर एक्सेट्रा. सो यहाँ पे हम टेक्निक्स की बात करते हैं सीबीटी की. सो फर्स्ट ऑफ ऑल कॉग्निटिव टेक्निक्स एंड बिहेवियरल टेक्निक्स. सो कॉग्निटिव टेक्निक्स क्या क्या होती है? बेसिकली कॉग्निटिव टेक्निक्स का फोकस मेनली होता है आइडेंटिफाई करना, चैलेंज करना और रिफ्रेम करना वो सारे डिस्टॉर्टेड थॉट्स को और अनहेल्पफुल थॉट्स को, और उनको एक रैशनल थॉट्स में कन्वर्ट करना. तो इसके लिए कुछ टेक्निक्स हैं, ये कुछ टेक्निक्स हैं, अदरवाइज बहुत सारी टेक्निक्स हैं. सो हमने यहाँ पे कुछ टेक्निक्स पे बात करी है, जैसे थॉट रिकॉर्ड. यहाँ पे क्लाइंट बेसिकली अपना जो भी सिचुएशन होती है वो यहाँ पे एक प्रॉपर एक डायरी में मेंटेन करता है कि क्या सिचुएशन थी, उसके बेस पे क्या थॉट आया, उस थॉट के बेसिस पे क्या वो बिहेवियर उन्होंने डेवलप किया, क्या उनको इमोशंस फील हुए, और क्या एक उसका ऑल्टरनेटिव थॉट आया. यहाँ पे क्लाइंट को हम जर्नलिंग भी बताते हैं. जर्नलिंग में क्लाइंट को जो भी उसके साथ सिचुएशंस हुई है वो राइट डाउन करे, जो भी उसके ऑटोमेटिक थॉट्स है वो प्रॉपर लिस्ट को राइट डाउन करे, एंड साइड बाय साइड जो भी उनको फीलिंग्स उसके साथ फील कर रहे हैं. हेलो,
Can you present it in English since I don't know Hindi?
Okay.
Thank you.
Okay, yeah. So third is Socratic questioning. In this Socratic questioning, we try that in the same session, client understand their other beliefs also. We basically try to questions that gently challenge the client and guide him to become actively involved in finding the answer. We ask the kind of questions like, what is the evidence of this thought? What is the evidence against of this thought? Is it what happens? What do you say if the same situation happened with your friend? So we ask these type of questions so that client is able to evaluate or reframe his particular thoughts. So now the next is cognitive restructuring. In this we try and we try to client to recognize and change the negative or unhelpful thought into a balanced and realistic ones. And last is cost benefit analysis. We try to ask the client what are the cons and pros of this situation. For example, the client says, I don't want to go in office party. So we ask the client, what are the pros of this situation? What are the cons of this situation? So this is an example of Socratic questioning. Here, this is a conversation between a child and a therapist, and therapist is asking, what is the evidence that nobody in the class likes you? And the child says that nobody sits with me in class. So here therapist evaluate that has this happened every time or just some days. She just try to evaluate that thought. Has someone ever smiled at you or asked to play? So now the child says Yes, last week a girl said with me in class, we eat lunch together and sometimes we play hide and seek during playtime. In this way, therapists help the child to evaluate their own thoughts and try to check if their thoughts are true or not. So the next thing the therapist asks, could there be a different reason why no one sat with you today? So now the child says, maybe I was late today and everyone has already sat down. So I had to sit alone. So this is how the Socratic questioning done. So here is a video. I want to show you video. Just give me a second.
Excuse
We are
me.
not able to hear the
Yeah.
voice.
Megha,
Yeah.
can you stop it? Can you just put a stop on the video? I think let the video get downloaded. Perhaps because of the internet speed, we are not able to hear the video. You can just switch on the tab, video tab, and let it download for a few seconds and then try to switch it on again. Because the audio is not, we are not able to hear the audio. You can try again, otherwise, if not possible, that's all right. Just try once more.
I think we can show the video in the last.
Okay, all right. So maybe Ashish can help us out in this, and you can proceed with your slides, Megha, and at the end you can coordinate with Ashish. I've shared you have his number with you, and
Okay.
you can coordinate with him later. Please proceed with your slides.
Yeah. So after cognitive techniques, we talk about the behavior techniques. Am I audible?
Yes, you are, but we can't see your slides. Can you share your screen again?
Ma'am, is it possible to explain the step three because I had missed the step three in the middle phase?
So if we have time at the end, we'll be happy to repeat the steps which have been missed by you.
Thank you, ma'am.
Okay, so now we talk about the behavior techniques. So basically, the main focus of the behavior techniques is to modify the unhelpful behavior that maintains psychological distress. So, what are the techniques in this? So, the first one is graded exposure. So, in graded exposure, we systematically confronting the fearful situations. The second is activity scheduling. So, in activity scheduling, we basically simply schedule and plan some manageable activities like some enjoyable activities, some mastery tasks, and some social activities. Like this is an example where four people are sitting together and watching a movie. This is like an activity scheduling to a client where we say to our client ki, where we ask to the client to go and go for a movie with your friends. A kind of an enjoyable activity. So the next one is role play. In role play, client practice new skills, confront difficult situation, or explore unhelpful beliefs. Basically, in role play, the client and therapist sit together, and therapist play a role of another person, like a boss. Basically, we can take an example. The that the client is feeling very anxious speaking in front of a boss. So here the therapist play a role of a boss. So now therapists teach client how to be assertive in front of boss, and also therapist also able to understand what are the other kind of beliefs a client hold about himself. So role play is a very effective technique in behavioral techniques, which helps the client to learn difficult, not difficult. Basically, it helps the client to learn some skills to so that he can practice in the real world. The next one is behavioral experiment. As ma'am said, behavioral experiment basically tests the validity of the belief or prediction through real life experiences. So how can they do in real life? Let's take an example. Uh, this is a proper office kind of setup. Here is a girl, she's a client. She think that they will think I'm dumb if they see my PPT. So she chose to not show her PPT in front of her colleagues. So now what therapist said to her? So therapists think that okay, now so now do a behavioral experiment and check the validity of your thought, is it true or not. So therapist give her a task to show a 5 slide presentation to other colleagues as a informal presentation type, and then realize what other people are reacting to it. So in this example, the girl asked other colleagues that I want to show you my 5 slide presentation. So are you interested? So in that manner, she showed her the 5 slide presentation. And what happens that everyone was very interested. They feel very excited and also love that PPT. So this shows that her thought was invalid because she was thinking that people will think I'm dumb if they see my PPT. But in real, what happened was people feel very happy. They were excited and also interested to show that PPT. So this was the proper step three, where we talk about the in step three basically we talk about all the techniques. We try to teach all the techniques to the clients, behavioral techniques, cognitive techniques, and so that clients learn all these things in the practical life. Now the fourth step is collaborative homework development. So basically, homework is planned together by the therapist and client. Most of the times, what we do as a mistake that we usually give the homework to the client and expect that they will do it in return. But most 95% times, clients will never complete their homework because they were not interested. They don't want to do that work. So basically in CBT, homework should be in a collaborative. Homework is a collaborative work. Homework should be planned together where both client and therapist agree with a particular work which a client has to do in the next week or in the next coming days, where client actively participate in deciding the task, which increase motivation and ownership. For example, this is a lady. She always shut herself in the room. She never likes to go outside. But uh, yeah, so what happened is that one time her previous therapist told her you should go outside for a walk in the park for at least 30 minutes, and she never did that. So when she changed her therapist, she gave her homework to at least go for a walk for 2 minutes with her pet, and in the same balcony, not outside of her home, but in the same balcony. And she did that homework. So this is a very important thing. At last, she has to homework should be in a collaborative, should be a collaborative work. So now this is a thought record. Exactly ये एक हमने homework client को दिया था कि वो अपने thought record पूरा complete करे. This homework is given to the client so that they complete their work. And this is the example of a client how they complete their homework. They particular write the situation, the thought, emotion, behavior, and the alternative thought. So now from this slide, Tanuja ma'am will take over.
All right. So we are coming to the last phase of therapy. Now, just like the first phase, the last phase is equally, or I would say sometimes the even more important than the first phase or the middle phase. This is a very sensitive phase of therapy because when you're coming towards the last phase, the client may have developed some sort of dependency on you, which you don't want. One of the aims, one of the goals, major goals of psychotherapy is to make the client independent and not overly dependent on yourself. And this you clarify once you start to come towards the termination of therapy. Of course, during the initial phase also you touch upon it, because during the initial phase, after you have done the history taking, you have established the baseline. By that time you know that approximately how many sessions the client would require, and over the next how many weeks or months approximately your therapy will be going on. So you do inform that to the client. But when you are conducting therapy and you are coming towards the end of the session, psychoeducation about termination is reintroduced in a more structured way. And this is done around, if you talk about typical CBT structure, which lasts up to 12, 13 sessions. So this termination ideally should start around ninth session. So termination is introduced as a natural part of progress, and frame termination as a sign of growth and reinforce client's role and strength. Okay, so termination should not be perceived as abandonment by the client, and it is just not the end, but we are trying to foster independence, and this is introduced as normal part of the CBT process. It's also important because it means that your client has made some progress, and this is how you should present the idea to the client also, that they have built the important skills and they have reached their goals to a great extent. May not be completely and entirely, but maybe if you have worked through your goals up to 70%, then you can start to work towards termination. You can tell the client that now you are ready to move forward on your own, and termination is not done suddenly, that okay, from tomorrow we are not going to meet. So you gently start to introduce the idea of termination. You plan ahead, you talk about it with your client, you understand that what is their readiness, are they cognitively prepared to even talk about it. So basically, it helps them cognitively get prepared for the process of termination and functioning independently. We have to focus on the feelings of relief, pride. Sometimes clients may also exhibit sadness because they are not going to meet you on a regular basis. So maybe some transference issues, if they are coming up, maybe in some separate session we can talk about transference. That could be there. In the end, termination helps the client see how far they have come, and it reminds them that now they have tools to keep going. Next, Megha, can we have the, so it, this is basically an example. It shows that, like when you help a child learn a bicycle, say for example, maybe initially you hold the bicycle, you hold the child, and you don't just leave them on their own. But gradually, once the child has learned to ride a bicycle on their own to an extent, you gently, maybe let go of one hand, and then gently you let go of the second hand, but you continue to show the child that okay, I am there, I'm holding, but actually you're not holding, you're allowing the child to ride the cycle on their own. So similarly, the termination phase is such that initially you help the client, you hold their hand, you help them or guide them, show them the direction. But eventually, once they start to practice those skills, they have brought those lifestyle changes in their life, in their routine. You let go of them. You make them independent and strengthen them, empower them to function independently without your support or guidance. So that was the analogy here. Next, Megha, please. Okay, so spaced sessions. This is a great technique when you're working towards termination. Spaced sessions, they happen near the end of the therapy, and when the client is, of course, doing better. And this means that the sessions are not required to be scheduled on weekly basis. They can be more spaced, meaning depending upon client's progress, you can schedule the next session after 10 days or 15 days or 20 days. When do we do it? We start the space sessions once you see that the client is reaching their goals and they're using their coping skills adequately, they are managing their life more independently. And how we do it, I've already told you that instead of meeting once a week, now you're meeting once in 2 weeks. And then gradually you move to once in a month. And every time you check with the client how they are doing. So, for example, if we have been working on managing anxiety, say for example, and after several sessions, they are using breathing techniques, they are handling tough situations, they are able to face their fears, do exposure, and prevent avoidance or prevent maybe compulsion. So you might say to your client that, okay, I observe that you have been doing really well. How would you feel about trying sessions once every 2 weeks so that you get some space to practice what you have learned independently? So, this will help the client build confidence in a gradual manner rather than just feeling that suddenly I have been dropped off or I have been abandoned by the therapist. So termination also, just like goal setting, termination also has to be collaborative and very gentle. So this is space sessions. And next, please. Okay, so this is again an example of what you tell the client. You have been applying the tools well and managing more confidently. So we can shift to bi-weekly sessions to help you practice these skills independently while still checking in regularly. Right. Okay, so again, this is very important, that how you prevent relapse in therapy. This also you work towards relapse prevention towards the end of the therapy. Next, we have some pointers in this. Okay, so as we move towards the end of the therapy, let's put up a plan together for what to do if old pattern starts to come back. So if you have worked with a client who has OCD, who's dealing with OCD, and they have managed to overcome a lot of their compulsions, now if OCD tries to enter their life back, if OCD tries to tell them that, okay, maybe you can, put this bottle properly, वरना तुम्हारे किसी family member के साथ कुछ हो जाएगा. So this is the first thought which is trying to re-enter your mind after weeks of working on this thing. Whether you should act on this thought or no. This is what we talk about in relapse prevention. So what if the disorder or the trouble or the anxiety or issues are trying to re-enter your life? In that case, what you are supposed to do? This is relapse prevention. It helps you feel prepared, more confident, so that you can handle it on your own. Please next. So you review and reinforce the skills. In relapse prevention, you revise from beginning till now. What were the homeworks? Where are they in terms of each homework? Are they doing journaling? How often? How often have you prescribed and how often they are able to do? And is it adequate? Are they doing deep breathing? Are they doing regular behavioral experiments? Are they challenging their negative thoughts properly? To what extent? What are the barriers and how to overcome those barriers? So you talk about the skills that you have taught them, to what extent they are able to implement them in their day to day. Identify warning signs. Now you help them learn how to identify a red flag sign. So for example, somebody with depression, and you have really worked on behavioral activation, they were not able to get out of their room at all when you started therapy, but now they are maintaining a decent schedule. They are going out, meeting friends, going for workout, going for the dance class, attending few classes. But now, over a period of time, they start to observe that they have started to skip one meal. Out of 3 meals that they were taking, they have started to skip meal. 1 day, 2 day, third day. Okay, this is a sign. Fourth day, they took off from work without any apparent reason. Fifth day, they did not go for the dance class. Okay, this is the red zone. Maybe in relapse prevention, a lot of times I try to help my clients identify what is your green zone, what is your orange zone, and what is your red zone. Usually, I tell them that during the orange zone, if you're able to identify that, okay, I'm going in the relapse is happening, or my issues are re-emerging. During the orange zone, if you're able to identify, come to the therapist immediately. If you are identifying your signs in the red zone, go to your psychiatrist and therapist together. So identify red flag signs, then develop relapse prevention plan. So with them, we help them that, okay, if this is happening, this is what you have to do. You don't act upon the first thought itself, which OCD is trying to again put in your head. You don't act on the first thought itself. Secondly, if you are in the orange zone, try to restart doing activity scheduling. Activity scheduling is, simply put, it's a timetable. So you're putting ticks and cross across the activities which you have been doing. So initially, if activity scheduling was helpful to your client, you tell them if there is a relapse happening, you immediately restart doing your activity scheduling. We can also help them identify their own people, their supportive people, like within their family, who are the people that they can go and talk to, who are their maybe friends who are little psychologically minded, who can support them, help them during that period. Encourage continued practice. So you tell them the importance of lifestyle change. So therapy is not a magic wand that you undergo 12 sessions and you overcome depression. Therapy is a lifestyle change. You identify your set of coping mechanisms. I strongly believe that we all have a set of coping mechanisms. If we continue to practice that set, we are able to maintain our emotional equilibrium. If we let go, any of us, if we let go of that, our mental health will start to deteriorate. So I have this one perspective that during therapy, you also help the client to identify their set of coping mechanisms, which till now they have not been able to identify. So you tell them the importance of continued practice, that you have to continuously continue to practice the skills that you have learned in therapy. Normalize setbacks. You tell them that improvement is not uniform. There may be ups and downs in the process of improvement. So it's all right if you have some sad days. It's okay if you sometimes don't want to go to your gym, you want to take one day off. It's all right. It's okay to take breaks, and it's okay to sometimes feel sad. We all of us experience sadness. In psychological disorders, a lot of time clients also get confused what is normal, what is not normal. So you help them identify on based on what indicators you can categorize or differentiate between what is normal, what is not. Then offer booster sessions. So once you have terminated the therapy, say after 12 sessions you have wrapped up therapy, but still you give them some booster sessions, in the sense, tell them that, okay, now come after 1 month or 2 months. 2 months mostly. 1 month you give spaced also while termination. So after 2 months, just come back and let's review how you're doing. And during that booster session, you can also revise the techniques, tools taught to them, or you can discuss if new issues are coming up. So booster sessions, they can go up to maybe 3 to 4 booster sessions can be planned in CBT. Next, please. Okay, this is basically we have developed a CBT cheat sheet so that it becomes easier for you. That if this is the disorder, this should be your focus, and these are the key CBT techniques which you can apply. And we have also provided a sample thought frame. You all can have a look at it. I think we have already discussed these techniques and sample thoughts. Can we proceed? This is another cheat sheet. This is for OCD, PTSD, and panic disorder. All right, so we are coming towards the end of today's webinar, but before you all leave, please stay back. If you have stayed till now, we'll not take more than a few minutes from you. So our CBT practitioner course is coming up next month. It's a 2-month course, and I, myself, Dr. Tanuja, and Megha Garg, we both are going to facilitate this course over a period of 2 months, and we are going to have evening classes for this. Megha, can we have the next slide? So this is how it is going to be from 4th August to 30th September. 3 days in a week, Monday, Thursday, and Friday, 7 p.m. to 8:30 p.m. And this is the facilitators are going to be myself and Megha Garg, and this CBT practitioner course is again organized by SoulaceSpace, which is my organization, and Loka, Sophiyana Loka, which is Ashish's organization. And based on this CBT practitioner course, we are offering two kind of certifications. One is level 1, which will be given to people who have completed their bachelor's. So, and level 2, which is provided to people who have completed their master's. The difference is that after master's, you can, of course, after undergoing this course, you can practice as a CBT practitioner. But after bachelor's, you cannot practice, but you will have better skills, CBT skills and tools and techniques. That's the difference between level 1 and level 2. And we are going to keep this course practical, like 50% practical and 50% theory is going to be there. Apart from it, I think this is mostly it. And let me just go through, if anything is left from my end, I'll just I think most of the things we have covered. Ashish, you have anything to say about the course, or maybe if I'm skipping anything from my end? Yeah, absolutely. So you can contact Ashish if you are interested in undergoing this course, pursuing this course. And before you all leave, I would also request if you can drop a feedback about today's webinar to Ashish. And also, one picture would be great if you all can switch on your camera if you're comfortable. We can have one picture for today. I hope I'm not missing out anything, Ashish. I have covered most of the things, right? And can we play the video, Ashish? Is it possible to play the video? Ashish, has Megha shared a video with you? Not able to see? Okay, actually, we had developed a video showing how to reframe the thoughts. Megha, any chances of showing the video?
Ashish, please check your WhatsApp. Yeah, yes.
You both have each other's numbers.
Excuse me, ma'am.
Yes.
If possible, could you please send the video on the group as well?
So sharing the video on the group won't be possible for us, but we are just trying to play it here only. Ashish is working on it.
Okay, ma'am, sure.
Meanwhile, if anyone has any question, we can take 3, 4 questions. Is that okay, Ashish? Can we take a few questions?
Yes, ma'am. Good evening, ma'am. Hello.
Hello, ma'am is busy right now. She's on call. Please wait for a minute.
Okay, ma'am. Okay.
Thank you.
All right, so I have been informed that we are time and we cannot extend this any further. We are most welcome. We'll be happy to have you join the upcoming course in the next month. And Ashish will be in touch with all of you on WhatsApp. You can drop your feedback and queries there. Thank you so much, everyone, for joining today. It was lovely talking to you all. And all right, bye bye. Take care.